Well, g'day and a warm welcome. Dr. Seal here, junior doctor in Australia, training to become a psychiatrist. And last week I gave a presentation to the staff on the ward where I work about EPSEs. Now, the first question I asked them is, what on earth does that stand for? Well, it stands for extrapyramidal side effects. And these are a constellation of 4 syndromes or symptoms, if you will. And these symptoms are heavily associated with some psychiatric medications, and they can be very disabling, and so much so that people have, become very depressed or anxious or agitated because of these symptoms. Okay, these are serious side effects. We have to take them very seriously. There are things we can do to ameliorate them, to improve them, but it's always a bit of a risk-benefit analysis, and sometimes, it's very difficult to treat. So the 4 EPSEs we're going to talk about are something called dystonia, akathisia, tardive dyskinesia, and drug-induced Parkinsonism. I almost forgot the 4th, but it's still up there. As a quick kind of background, the reason it's called the extrapyramidal side effects as opposed to pyramidal side effects, these are just referencing different neural tracts. Okay, we have a pyramidal tract that goes through kind of these structures in the brain that look like little neuronal pyramids, and those tracks, the pyramidal tracts, are all about conscious motor movement. I'm in control of me saying, yeah. So for example, if I say, yeah, this is a great YouTube video, that extension of my fist has a conscious flexion of my tricep to extend the arm. But what I'm not so conscious of is that I have to relax my bicep to allow my arm to extend. And that unconscious relaxation is the extrapyramidal tract. And when that isn't working well, I could have stiffness because the tone of the muscles might not be normal. And so you get hypertonia as one of these extrapyramidal side effects, which we'll talk about. So that's the reason they call this terribly long word. It's just based on the different neuron tracts that are affected. And often it's involving the basal ganglia. If you want to know the long name for the part of the brain that's affected, it's often either the nigrostriatal dopaminergic pathway is the most commonly affected in these set of symptoms. I guess that's for the med students who have the exams coming up. So I'll give a little, definition for the 4 symptoms we're going to talk about, and then we can talk a little about why they happen, what we can do to improve them. But I would just like to say that if you know someone or have personally experienced any of these kind of symptoms, it is so valuable to hear your story, and putting it in the comments below, it's just really interesting and helpful for other people. Some people might find that the comments section is the most valuable part of this video, and that will be fine with me because that's, it's kind of like a little community down there of people sharing their stories. So please do share your stories if you've had it, and let us know what worked to help their symptoms. So akathisia. Akathisia is pretty horrible. It's an inner restlessness, a need to move that is not satisfied by moving. So you do move, but it's still there, and it's distressing. It's uncomfortable, and some people become very anxious because of it. And it's unremitting. It's always what you'll see in a patient is someone kind of pacing on the spot, or crossing and uncrossing their legs, or their leg will be bouncing while talking to you. And I will put some links to some footage so that you can see it in the B-roll here. But it's very unpleasant. Wow, that was hard to hear. But that was him trying to sit still as best he can, and it was extremely difficult. The akathisia was unrelenting. I think we should watch that again. Look how uncomfortable he looks. Wow. Dystonia is a also quite distressing symptom and can be absolutely an emergency. Dystonia happens when we talked a bit about the tone of the muscles. It's essentially when muscles are involuntarily flexing, and can happen anywhere in your body, and it can even happen in your throat, and that can cause serious airway problems. It can be very painful as well, and if it's sustained, you can have muscle breakdown, and it can cause essentially muscle breakdown. Parkinsonism is interesting, and it's interesting because it's not Parkinson's disease. That's important to note. It is not Parkinson's disease, but it looks so much like it. It's the same kind of symptoms. You have this mask-like face. You've got this slow movement. The way that they walk is shuffled, and then you get the same kind of tremor and stiffness in the muscles. And then the final one we'll talk about is something called tardive dyskinesia. Not a nice name, it's not named to be easily remembered. It's a tricky one, but it's something that happens late, and that's what tardive means. I don't know if you speak French, but in French, tard means late, and tardive is late onset, and dyskinesia just means uncontrolled movements. So it's essentially a late onset of uncontrolled movements, but really, most commonly, I don't actually know the percentage, but more than half the time, it's the face that's affected, and it's perioral, around the mouth movements. So you might have tongue poking, lip smacking, all strange kind of perioral, around the mouth, uncontrolled movements. Now, people can control it and suppress it if they try, but then if they get distracted, it comes back, and sometimes even worse. Yeah, so that's the 4 things to talk about today, guys. So let's get cracking on. So we spoke about what akathisia is already. It's worth noting that we don't really understand how it happens. We don't understand the kind of biology about why people get akathisia. We know it's related to dopamine because it's with dopaminergic medications or anti-dopamine medications that you see it, but it's just not fully understood. So it relates to the term is monoamine neurotransmitters, which include dopamine, serotonin, and norepinephrine. These are just the chemicals that different neurons are using to talk to one another, but we don't really know why. Now, obviously, when someone is feeling very anxious, they also can have tremors and kind of leg tapping, and they can kind of feel like they need to move. Anxiety is a very physical illness, which people don't always appreciate. But akathisia is very intense, and it's essentially really hard to detangle when is something akathisia versus when is something anxiety. And often akathisia can cause anxiety, and often anxiety can look like akathisia. Fortunately, the treatments are very similar between the two. But the key thing to kind of use to find out if someone is experiencing anxiety versus akathisia is really looking for the risk factors. So things like having medications that are associated with akathisia, and that is considered the high potency antipsychotics, usually the first generation. So things like zeuglopenthixol, flupenthixol, haloperidol, these are all associated with akathisia. If it's been used chronically, if there's a rapid change in dose, if there's a history of what we can call an organic brain syndrome, so some brain illness like a trauma or a bleed or chronic alcohol use, a dementia, HIV, encephalitis, these kind of things, and also if there's multiple medications. So before we talk about the treatment of akathisia, let's also just talk about drug-induced Parkinsonism. And then we can talk about the treatment, because the first steps in treatment are similar for both of these things. Drug-induced Parkinsonism. Personally, my first time as an intern seeing a patient with Parkinson's, drug-induced Parkinsonism, I thought they were being rude. I was so naive, and because Parkinson's disease affects your muscles of facial expression, it gives you what is called like a mask, like faces is the term, but it's a kind of really expressionless face. And I thought this person was kind of not interested in me because their eyes were like this while I was talking, and I was, just trying to build a rapport, a connection, but I wasn't getting anywhere. And but then when they would speak, although it was monotonous and soft, they were helping me and talking about the things I needed to hear. And so I was a bit shocked, and only after the fact that after seeing a couple of patients with it did I realize it wasn't a personal thing, it was just the illness. But really the three parts of the Parkinson's syndrome are: 1, tremor; 2, rigidity; and 3, slowed movement. So let's talk about them in each part. So tremor, there's lots of different tremors, and tremors are hard. If you put a piece of paper, I have a piece of paper right here, on people's hands, a lot of people will have a fine tremor. Some people have intermittent tremors, some people never know why. Who knows? But I guess there's a wide differential with tremors is what I'm trying to say. But a Parkinson's tremor is a little bit different. It is a 2 hertz usually, kind of rolling tremor. So it's usually about that much. Yeah. Now, in Parkinson's disease, it might be one side more than the other, but in drug-induced Parkinsonism, it's usually both sides equally. And it's persistent while they're awake. Now, with rigidity, that's in their muscles, so they might feel a stiffness. And if you, as a doctor, do an examination of muscle tone, where you move the muscles, it'll feel like a cogwheel, because the muscles are spasming and not being kind of relaxed in a normal, floppy way, as they should be. And slowed movements is what it sounds like. So walking is we'll see some footage in a second of the shuffling gait. If you ask them to tap as quickly as you possibly can, it's often it feels a bit uncoordinated and slow. Doing kind of coordination tasks like tapping each finger like that, that's very difficult to do quickly. And if you guys have seen it before or have experienced it, please put your comments down below. So now let's look at some footage of people with drug-induced Parkinsonism. I think the first link is actually someone acting. Yeah, so this is an actor. Okay, so now we can see this. This is a neurologist, I think, who's kind of mimicking the Parkinsonian gait. You can see the shuffling small steps and the tremoring hands and the stooped posture. That's all from the stiffness. And now he's going to try and turn. But what we'll see is that turning is very difficult to do in one step. So normally a person would just take a step and turn, but someone with a severe Parkinson's will have lots of little steps like this. So in this footage, kind of hard to tell, that the person holding the camera is speaking to this person, and this facial expression, is kind of blank face, is very characteristic of Parkinson's disease. He's actually talking, but you can't see his lips move much. Here he's asking to do this as quickly as you can, and you can see how kind of difficult it is for him. A bit better on that side, but not completely normal. You can see that there's something slowing it down. Let's have a look at his walk. So yeah, it's not the most severe I've seen, but it is probably quite disabling. But really, I think with this footage, the most striking thing to me is just the lack of facial expression. If you hear the audio of the footage, and I'll put the links down in the description, but if you listen to the audio, he's speaking, but there's just no kind of facial response. Here's an example of just a resting tremor. It's really affecting just the left hand in this one. And I know that before I said it can affect both hands, but guess what? Diseases don't read the textbooks. So sometimes just because the textbook said that it's usually bilateral doesn't mean it's always bilateral, both sides. Okay, now let's talk a little bit about what we can do about drug-induced Parkinsonisms and akathisia. Well, as a kind of psychiatry doctor managing a patient with these symptoms, we have to kind of know a couple of things. We need to do a full assessment, the whole works, to really understand what is the need for treatment. If someone is, at risk of hurting other people or themselves because of a psychosis, well, we know that they need an antipsychotic medication. And so when we're thinking about what to do, we have to take into account the risks of changing that medication. We also have to understand how disabling is the dystonia, or sorry, the Parkinsonism or the akathisia, to decide the risk-benefit ratio. But say we do want to reduce the EPSEs, what we can do is we can choose to reduce the dose of medication. Again, that doesn't always, that has to be discussed with a psychiatrist. We could switch to a antipsychotic that is less akathisia causing. The sad reality, though, is the antipsychotics that don't have these EPSE side effects, the extrapyramidal side effects, they have other side effects like weight gain and that kind of metabolic syndrome, so weight gain, high blood pressure, blood cholesterol issues. So it's always this kind of what price are you willing to pay. But one of the options is also to consider clozapine. Clozapine is a very interesting, unique antipsychotic. Doesn't really target the dopamine receptor subtype that we're all talking, like there's different dopamine receptor subtypes. Clozapine doesn't hit the one that usually causes akathisia. So it's a good option and it's very effective. Probably the most effective antipsychotic out there, but there's also very significant side effects and very intensive monitoring. So those are the things you can do to the antipsychotic, but also you can add anti-akathisia or anti-Parkinson's medications. So if you see this text here, some akathisia medications can include propranolol or mirtazapine, and in some cases benzodiazepines. But of course, with all these things, you have to make a risk-benefit analysis. Please remember, this is not medical advice. This is general education. These are things we have used, but every patient has, their own. You need to talk to a doctor before doing any of these things. But you can talk to your doctor about these ideas. Now, anyway, moving on to anti-Parkinson's medications, a bit more tricky because, often you would want to boost up dopamine if someone's had Parkinson's disease. So amantadine is a kind of dopaminergic medication. It's an agonist. It binds to the dopamine receptors to stimulate them so that it improves the symptoms of Parkinson's disease. But guess what happens when you give someone dopamine who has a history of psychosis? Well, it increases their risk of psychosis again. So you might destabilize the mental state. So it's quite risky. And I haven't really seen many people, I've probably only ever seen one person be on it in a psychiatry setting. But anticholinergics are also used. The way that they work, I can talk a little bit about it when we talk about dystonia because it's a similar mechanism, but these symptoms can essentially happen if there's an imbalance between the acetylcholine in the brain and the dopamine in the brain, specifically in this very long-named circuit called the corticostriatothalamic corticotract. Don't know why they do this to us, these horrible names. Anyway, there's a balance of acetylcholine and of dopamine in that circuit. When you block all the dopamine, it goes down. The acetylcholine stays high. These are all just chemicals in the brain that neurons use to talk to one another, by the way. And you get the symptoms when you have this imbalance. But if you give an anticholinergic, you can lower the acetylcholine so that they're balanced with the dopamine, and you've got the symptoms improve. And that's the same mechanism as what we see in dystonia, which we're about to talk about. So look, I talked about dystonia separately because dystonia is it can be very serious and an emergency. So it's good to know about, it's good to recognize, and it can be very scary to see, but actually it's very treatable. And if someone gets the right medication, first you need the right diagnosis, you need to know it's dystonia. But if someone gets intramuscular benztropine when they're having a severe dystonic reaction, that is, I won't always say always, but that will very, 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 very often produce a resolution of symptoms within a very brief amount of time. 5-10 minutes, you see a change. So I remember seeing patients who you can't understand what they're saying because they have dystonia of their tongue and mouth and jaw and neck. And so they've got this fixed flexed position, right? That's what dystonia is. It's contracted muscles that you cannot relax, and it's painful. And you cannot, if the tongue is a muscle, right? If that is flexed and fixed, you cannot express words. So I've had people who you can't understand what they're saying. Obviously you can't swallow medications or have food or drink water when you're it's very disabling. And so, you give them intramuscular anticholinergic medication and in 5 minutes they go, oh my gosh, thank you so much. I was saying that I was getting dystonia and I need some water, and then things move on. So yeah, there's lots of different fancy Latin or Greek names, I think Greek, for the different muscles that get flexed. So you have torticollis, retrocollis, tortipelvis. Ocular gyrocrisis is when the eyes kind of get contracted. So sometimes you see a patient and you think they're rolling their eyes at you. Actually, no, it's a dystonic reaction with the muscles of the eye looking up. So yeah, it doesn't really matter. I guess it's important to just know that if they're having a laryngeal dystonia where the larynx is flexing closed, then that's an emergency and you need to get to an emergency department. And you'll know that because their voice will sound different. It'll sound like more, their voice will start having episodes of sounding well, what's happening is the vocal cords are dystonic and closing, and so the voice kind of and they'll try and cough through the vocal cord contracting. So I guess if you have any kind of muscles in your body kind of becoming dystonic and the voice changes, just get to an emergency department right away. That's my best advice. So it's similar risk factors as with the other kind of Parkinson's disease and akathisia we talked about. So high potency antipsychotics can do it. And if you've never had an antipsychotic before and you get a big dose of antipsychotic, it's very common. And if I've had someone, so for example, if someone has a psychotic agitation and they've tried to attack staff or they're trying to headbutt the wall to get out of spirit or something, I don't know. These aren't real cases, by the way. This is just examples I'm coming up with. Then you might have to sedate them with a high potency antipsychotic for their safety, but you can give them an anticholinergic with that if it's a high dose, because you don't want them to like lose consciousness and then be in kind of lose consciousness. You don't want them to be sedated and go to sleep, but then have episodes of kind of dystonia overnight, because that can be really painful. But whenever I chart these like high potency antipsychotics, I'll always chart what's called a PRN of anticholinergic. So it's at if the patient asks for it or the nurse notices it, they can just give it. But if they don't notice it and there's no issues, then they don't have to give it. So PRN is kind of like as required. So let's look at some footage of dystonia. So this is cervical dystonia from the JAMA Network YouTube channel. So yeah, when you're looking at this gentleman, you can see this kind of, if you're walking past him, you'd just be like, oh, that looks a bit strange. But he's trying to look straight, and his muscles, against his will, are flexing him away from where he wants to rest his head. Now it's the front sternocleidomastoid. Now it's that's the neck muscle. That's the sternocleidomastoid there. No tremor there. No weakness. Walking, obviously, with that dystonia. So very disabling stuff. The background of this patient is that it's not an antipsychotic-induced cervical dystonia. It's got a genetic syndrome problem. But if you see that in a patient on antipsychotics and they've had it after the antipsychotics, then it's probably antipsychotic-induced, and you can give them anticholinergics. Yeah, this is an antipsychotic-induced dystonia, and this poor man is trying as hard as he can to follow the instructions of holding your hand like this, and then like this, and then like this, and the muscles are just flexing without his, against his will. So he probably need multiple. Like usually, you give a bit of a course of like 3 to 5 days of the anticholinergic. So yeah, that's a good overview of dystonia, and we talked about the treatment with anticholinergics. Benzodiazepines are sometimes used short term, of course, and you probably shouldn't be on that medication long term if possible, if you're getting dystonic side effects from the medication causing it. So it's always worth considering a switch. Now let's talk a little bit about tardive dyskinesia. It's the last thing to talk about. I guess the reason it's called tardive is because the average time to onset is 7 years after the antipsychotic has started. Have a look at this video, which shows someone with tardive dyskinesia. So he's trying to stay still here, right? And you can see that, this is before and after a treatment, by the way. So this is after treatment. But in the before, you can see that's the perioral movement. And you could see, I'll just bring it back to the fingers. Look at the piano like playing fingers and the toes all moving. That's all involuntary. And then after treatment, here it is, much improved. Then it goes back to the face. As I was saying, tardive dyskinesia often affects around the mouth and the tongue. So that's him trying to keep it still. That's him trying to do this action. Still a bit of a tremor, but much improved. And some people, with mild tardive dyskinesia aren't even aware they have it, which is why it's important for the doctors to assess the patient. And when we do our assessments, we do different scales, like one's called the AIMS scale, one's called a GASS, G-A-S-S, Glasgow Antipsychotic Symptom Scale. The AIMS is Abnormal Involuntary Movement Scale. And we have these different scales to try and, as closely to possible, objectively measure the symptoms that we see. So yeah, it can be mistaken for other things like akathisia or anxiety or a tic disorder, but it is essentially its own EPSE because it's got this unique mechanism of action. Actually, we don't really know why it happens yet fully, but it is probably to do with dopamine receptor hypersensitivity because so many have been blocked with the antipsychotics for so long. Your body produces so many of them, and then you get a dyskinesia because of the hypersensitivity to dopamine. And so clozapine is a really good idea. So in terms of the treatment for tardive dyskinesia, you have to change antipsychotic, or at best you want to do the same thing as before: reduce the dose, consider a switch, and really consider clozapine. It's really helpful because it doesn't hit the dopamine receptor that we're worried about. But there are other kind of medications that can help, things called like tetrabenazine. And these are, well, it's a pretty rare side effect, and so I haven't seen tetrabenazine be used that much yet. But just as you saw in that footage, the before and after of treatment is quite significant. So it's definitely worth considering. All right, guys, that was a thorough overview. I'm not sure how long it lasted. Yeah, about 30 minutes. That's a big video. Thank you for staying tuned. If you experience these symptoms, comment down below. I'll try and answer any questions you guys have. And I just wish you all a beautiful day. I understand these symptoms can be disabling, but hang in there. It takes a bit of time, but when you do find the right kind of medication cocktail to treat psychosis, it is obviously, of course, worth it because of how problematic or disabling or troublesome psychosis can be. So please hang in there. But that's it for this video. That's my overview of the extrapyramidal side effects. And I just wish you all a beautiful day full of love and connection. Call a friend, tell them you love them, and I'll see you all in the next video. All right. Bye for now.